Hello guys, this is Dr. Ammar Abajamiya from goodrationale.com, and if you want to know everything about fibroids, then you are absolutely in the right place. So let's dive right in. Starting by definition. What is fibroid? Fibroids simply mean a benign tumor of the myometrium. A benign tumor of the myometrium. And what is the myometrium is composed of? It is composed of smooth muscles, here in the red, and fibrous tissue, represented in black. So it's a benign overgrowth of smooth muscles and fibrous tissue. But there are another terms that are frequently used instead of fibroids. They are similar. Same thing, fibroids and fibromyoma. This is one. Fibro from fibrous tissue and myoma means smooth muscles. That's the origin of the disease. And there is leiomyoma, which simply means myometrium. Now, how common is fibroids? It is very common. Actually, it is the commonest cause of pelvic swelling in females. Also, it is the most common cause of benign tumor in females. However, only few patients experience symptoms. Now, if this is an overgrowth of the myometrium, so what causes this overgrowth? It must be something that induces proliferative changes in the myometrium, and that is estrogen. Estrogen induces proliferative changes in the myometrium, but in fact, that's not precisely the cause. Rather, it is unopposed hyperestrogenemia. Unopposed hyperestrogenemia. You know that there is another hormone, which is progesterone, that antagonizes the effect of estrogen. It antagonizes the proliferative changes that, if estrogen is alone, could produce. So, in pregnancy, for example, the enormous amounts of progesterone protects against the overgrowth of the myometrium. That being said, who do you think are the most liable population to get this disease? And these are the types of people who have been exposed to long periods of hyperestrogenic states. I think you know it fair enough. These are women in their 30s or 40s, 30s or 40s, who have never got pregnant, or who have low parities, so nulliparous or low parity, and they are in their 30s or 40s. Also, there is a note worth mentioning here that fibroids have been found to be much commoner in dark races. That's the introduction. Now, let's take a look about the pathology of the fibroids. And that can be summarized in an acronym, simple acronym. First one is M, then there is 4 S's, there is 3 C's, and 1 M. Let's take a look at the first letter, N, the number. It might be solitary or multiple. Solitary or multiple. In fact, it may reach hundreds, like hundreds. Okay, so that's the first one. Next, the first S, which is the site. Let's talk about the site. 95% of all fibroids are corporeal, like from here to here, corporeal. 95% corporeal in the corpus. Okay. Of those, 60% are intramural, like here in the middle. Intramural, 60%. Okay? In fact, all fibroids, almost all fibroids, starts as intramural fibroids, or you can call it interstitial fibroids, interstitial fibroids. This intramural or interstitial fibroids may grow towards the peritoneal cavity, towards the abdomen, and becomes, like there, and becomes subserous fibroid. Or it may grow towards the uterine cavity and becomes submucous fibroid. Let's talk about the clinical significance of both of them. The first is the subserous fibroids. Its percentage is about 20%, and this submucous is about 50%. Now, the subserous fibroid, there is a complication that we will talk about in the next section when we talk about the secondary changes of fibroids, that is chronic torsion. In that case, there are rare cases that this subserous fibroids grows toward neighboring structure and becomes parasitic, like it takes blood, it steals blood from surrounding structures. What about the submucous fibroids? It may grow towards the uterine cavity, okay, and becomes a typoid polyp with a stalk like that, okay, and becomes a typoid polyp. Now, these are the corporeal, 95%, 60 for the intramural, 20 for the subserous, and 15 for the submucous. Altogether are 95. Then there might be in the cervix, which constitutes about 4%. Now, what about these? It also starts within the walls of the cervix, but it may go towards, let's erase this for a minute, okay? It may go towards the cervical canal, okay, and change the shape of the cervix. Like if this is the cervix, it becomes like a parallel shaped cervix, okay? Also, it may protrude outside into the ectocervix and becomes a cervical polyp. That's for the cervix, 4%. Then there is 1%. Where does it go? There are structures outside the uterine cavity, which is the broad ligament, the ovarian ligament, the round ligament of the uterus. Let's take a look at this. First, here you can see the structures, the sites. Here you can see the sites of the fibroids. Here the intramural, 60%, submucous, 15%, and subserous, 20%. Here's the broad ligament, the first site we talked about after the cervix, which is a wide fold of peritoneum that attaches both sides of the uterus to the walls and floor of the pelvic cavity. Also, it might be found in the ovarian ligament, which connects the ovary to the lateral surface of the uterus. Then we've got the round ligament. The round ligament, we can see it here. The round ligament originates from the uterine horns, exits through the deep inguinal ring, enters the inguinal canal, and continues into the labia majora, where it spreads and mixes with the tissue of mons pubis. Okay, here is the sites. Now let's move towards the C's. Here is the site. So we talked about the site before the C's. First the site, then the size. The size. It may be microscopic, like we're talking here, ceiling, to very huge, like very huge. Like you can imagine, it may fill the peritoneal cavity. Next S would be the site size shape. Shape. It starts as spherical. We're talking here without a pedicle, not becoming a polyp. Spherical, and then becomes, as it enlarges, it becomes compressed from the surrounding structures. Here is site size, shape, and supply. The fibroids may get their blood supply from one of two sources. Either here is the fibroid, and here is another fibroid. Here it developed a pedicle and becomes a polyp, and here is just a pseudocapsule of surrounding myometrium is around it with blood vessels. So the fibroid gets their blood supply either from their capsule or from the pedicle entering from there. Okay, let's talk about this for a moment. If the fibroid is getting their blood supply from their capsule, you can imagine that, and that's right, the central part becomes necrotic and degenerated as it's far away from the blood supply, and the peripheral parts are getting the fat from the blood vessels and undergoes saponification reaction and hence get calcified. So calcification at the periphery and central necrosis and degeneration. What if the fibroids have developed the polyp, and its blood supply is from their pedicle. You can imagine that the tip of the fibroid becomes ulcerated as it's far away from the blood supply and gets infected. So the N, we talked about that, site, size, shape, and supply. Let's move to the C's. First C is the capsule. As we said, it does not have a true capsule. In fact, the capsule is composed of the compressed surrounding myometrium. Like if that's a fibroid, the surrounding compressed myometrium is their capsule. That's where the fibroids get their blood supply from. Okay, consistency. Consistency. The fibroid can be firm, and the more firmer means the more fibrous tissue that it has. Okay, like firm, like you can feel the tip of your nose, or it may be hard, like you can feel the frontal eminence, for example. And when it can be hard, if it gets calcified, we're talking here about this guys right here. Okay, or it may be soft, like you can feel the lobule of your auricle. Soft, we are talking here about in pregnancy, like there is a progesterone effect. Okay, or degeneration, which we'll talk about in the secondary changes in the next video. Or it can be very soft, like we're talking here about brain-like, very soft. Here we can see it in malignancy, like sarcomatous changes. So that's the C. Let's move to the here's the last C. Okay, last C is the cut section. What you can see if you have a cut section through the fibroid, you will see a holy appearance, which is paler than the surrounding myometrium. Here. Okay? Let's take a look at this picture right here. Okay, we forgot to mention this. That's okay. Here is a fibroid. Where does it come from? As you can see, here is the bladder. That means this is an anterior view. So this should be the right and this should be the left. So this should be the right ovary. So where is this huge fibroids coming from? Coming from the broad ligament. But which broad ligament? The right broad ligament, of course. Next picture. Here is a CT scan of a fibroid from the ovarian, from the round ligament. Okay, here is the wholly cut surface of fibroid. What is a wholly appearance? It means that it has spirals, like you can see here, and concentric circles. Here is concentric circles. Okay, that is the cut section of the fibroid. Let's move to the last letter, which is M. That is the microscopic examination, what you can see at microscopy of the fibroid. As we said earlier, it is fibromyoma, fibrous tissue and smooth muscles that we will see. Let's take a look. Here is fibrous tissue in pink and smooth muscles. Let's see another picture. Fibrous tissue in pink and smooth muscles. Another fibrous tissue in pink and smooth muscles. In the next video, we will talk about the secondary changes, the pathological changes of fibroids. Thank you.